discoid resection of deep rectosigmoid endometriosis with the assistance of a laparoscopic ultrasound probe. The authors have the following disclosures. Our objectives are to 1. Review the techniques used in the surgical management of deep endometriosis of the rectosigmoid. 2. Demonstrate the use of laparoscopic ultrasound in the setting of endometriosis. And 3. Discuss the use of a sterile discoid resection for the management of a deep rectosigmoid lesion. Deep endometriosis, previously referred to as deep infiltrating endometriosis, is characterized by the extension of endometriotic implants beyond the peritoneal surface. At times, this can involve adjacent structures, such as the bowel, and can be associated with symptoms such as dyschezia and/or hematoschezia during menstruation. Surgical management of deep endometriosis involving the bowel, specifically the rectosigmoid, often depends on the depth and size of the lesion. Management options include shaving, discoid resection, and segmental resection. Shaving is considered a conservative surgical management approach and is often used for nodules that do not extend beyond the external muscularis. Discoid resection is considered another conservative option, but can be used in the setting of lesions that extend beyond the inner muscularis and remain less than 3 centimeters in maximal diameter. This technique involves removing a portion of the bowel without requiring a complete end-to-end anastomosis. On the other hand, segmental bowel resections are typically reserved for cases with large endometriotic implants, multiple nodules, infiltration beyond the muscularis, or luminal stenosis. Initial surgical planning in the setting of deep endometriosis often relies on preoperative imaging. However, distortion secondary to high-stage endometriosis and adhesions can lead to inaccurate estimates of the size, depth, and concurrent organ involvement of these lesions. With this, surgical teams are often forced to rely upon tactile response and intraoperative decision-making to determine how best to proceed in the management of deep endometriosis. Laparoscopic ultrasound has been used in the assessment and management of some intra-abdominal malignancies, particularly in the setting of gastric, adrenal, and hepatic tumors. Its use in gynecologic surgery has been limited, but shows promise in the management of deep endometriosis. This tool can provide real-time feedback on the size, depth, and involvement of surrounding structures. Such information can help to ensure the best surgical approach is selected. We present a 47-year-old female with a known history of stage 4 endometriosis with recurrent chronic pelvic pain and pressure-like symptoms around the rectum. She had a previous shaving of deep rectal endometriosis at the time of total laparoscopic hysterectomy, bilateral salpingectomy, and excision. A follow-up specialized preoperative ultrasound revealed an ongoing or recurrent nodule that was located at the anterior rectosigmoid junction, measuring roughly 2.5 centimeters in maximal diameter. This was confirmed with a high-resolution rectosigmoid MRI protocol. Images seen highlight the lesion extending into the muscularis. The patient declined ongoing hormonal suppression and desired definitive surgical management with excision. On initial inspection of the pelvis, the lesion was difficult to identify. This was because of the patient's previous surgical history, where an area of deep endometriosis of the rectosigmoid colon was shaved and subsequently oversewn. This caused a nodule to lie deeper within the muscularis and thus was harder to identify with inspection and tactile feedback alone. The pelvis was irrigated with fluid to minimize artifact. Simultaneously, the bowel was filled with sterile water using a 14 French catheter, and an Alice grasper was placed more cephalad to ensure the rectal fluid remained within the area of interest. These techniques allowed for the establishment of an appropriate acoustic window. The laparoscopic ultrasound probe was then placed in the region. The bowel was then traced until the lesion was clearly identified near the rectosigmoid junction. Intraoperative images provided in-time feedback highlighting the depth and extent of the lesion. Here there is evidence of the lesion extending into the muscularis of the rectosigmoid colon. In a joint decision with general surgery, it was determined that the most appropriate and conservative option was a discoid resection. Following a bilateral oophorectomy, general surgery began the discoid resection by confirming the location of the lesion with a rectal probe. The right pararectal space was opened. A suture was then used to outline the lesion and aid with invagination of the rectosigmoid lesion. A circular transanal stapler was then inserted rectally, with the head and tail of the stapler placed superior and inferior to the lesion, respectively. Attention was paid to ensure the partial anastomosis was appropriately aligned. Once the lesion was completely invaginated, the stapler was fired, resecting only the area of interest in a sterile manner. The region was then oversewed. Following resection, a rigid sigmoidoscopy and bubble test was performed and was negative. The ultrasound probe was then placed over the region to ensure complete resection of the deep endometriotic lesion. Review of the post-resection images illustrates complete removal of the lesion. In summary, laparoscopic ultrasound is a beneficial tool providing real-time feedback on the extent of deep endometriosis that may not otherwise be attained through standard preoperative imaging or laparoscopy. In particular, it can help to identify difficult lesions, as seen in this case, where previous shaving and oversewing of the bowel made it difficult to recognize the lesion with inspection and tactile feedback alone. It holds potential to ensure that when shaving is selected, the entire lesion is appropriately removed. Such information can also help to ensure the most appropriate and conservative surgical option is selected. Thank you for your time, and thank you to all our collaborators.